Anyway, all right, so what did you say, 27? 28. All right, so here we are, ScottCast, the podcast, 28, which is hard to believe. And we're joined again by Dr. Ivan Castro, which he's back by popular demand. He doesn't know he was popular, and he doesn't know he was in demand.
Deafening.
But the overwhelming response was, bring that guy back. So here he is. So it's been an interesting month or so since I did my last podcast. Lots of wacky stuff. The market was kind of sucky day before yesterday, and of course I got all kinds of panicked phone calls, and the world's coming to an end, and now it's back up pretty much to where it started, which is kind of par for the course.
I haven't checked in the last 5 minutes.
Good for you. Yeah. Yeah. You make a great client. But what we don't want to talk about markets today directly. What I was interested in, and you and I have had this conversation many times over many beers, which is somewhat ironic, is that there seems to be a disparity in outcomes for folks on one end of the financial spectrum versus another end. And you and I both came from, not a bunch, and so we've seen the other side of it. My rural Florida upbringing let me see a lot of those outcomes, and many of them were not good, especially in the area of diabetes. But I wanted to talk a little bit about the statistics and then what you've seen in your practice. Now, your practice currently, although you've been in the general public medicine, at the top of general public medicine here in Central Florida, so you know those numbers, which is going to be a great way to cast one against the other, is in your practice now you're dealing typically with people in the top 1% to 5%, I would say, of wealth, especially in this part of the country. But what we know is the outcomes in terms of life expectancy. I was kind of cheating and digging up some statistics. I'd like to say I knew them by heart, but I don't. But I was somewhat familiar with them. Is that the life expectancy gap from the top 1%, so people at the top 1% of income or wealth, to the bottom 1% is 14 years.
Yeah.
14 years.
I would not question that number at all.
So if you're living into your mid-80s as a wealthy person for a variety of reasons we can go into, folks on the other side are only living into their 60s on average, which I've seen. I've seen that played out. Mm-hmm. And the contributing factors are, and this is your part because you're the doctor, I don't know if you're aware of that, is diabetes, exercise or lack thereof, education on healthcare, getting access to regular healthcare, the food that we eat, the exercise that we don't get. So maybe you start from the beginnings of your earlier part of your career where you dealt with the general public and some of the trends you saw there with people who didn't have access to information or didn't have the wealth or money to acquire good health care versus what you see today.
Sure. So when you are going through medical school and residency, you tend to get exposed to the lower echelon of society. They're the ones that typically will go to a large teaching hospital where they can get access to medicine, and a lot of the times it's subsidized or frankly free. And then when you go into a general practice, it will depend what city you live in, what part of the social strata you deal with. And then, as you mentioned, in my current practice, I deal with the upper strata, and my practice is in Winter Park, which is an upscale basically city that's kind of a suburb of Orlando. And
I think 32789 is the wealthiest zip code in Central Florida.
Is it?
I think so.
Yeah. And so if I go back to thinking about the kind of patients I took care of when I was a resident, I was in Santa Clara, and it was kind of at the height of HIV, AIDS, and so forth. So we dealt with a lot of that, which of course meant not just people who were homosexual, but people who were drug addicts.
Right.
And that was, sharing needles would be another way to get AIDS. And these people were generally quite sick, and I don't mean just from AIDS. I mean, a lot of them barely had any teeth, were either overweight or malnourished. Some were homeless. And so they would only access the medical system when they had a crisis or absolutely had to. And as you ascend the ladder to middle America, you still see a lot of that. I think the middle American doesn't have a lot of disposable income. And even if they have health insurance, they still have co-pays and different out-of-pocket expenses, which is going to limit their wanting to see a doctor or even get a physical for fear of, one, finding a disease and the associated costs with that, or two, the associated co-pays, or three, the cost of medications. As you move up the ladder, you're going to have people that actually realize that just having money isn't worth much unless you have your health. And so then they will make a point of making their health a priority and educating themselves as to how you go about taking care of yourself. And one is to have a solid primary care doctor that can guide you and do the appropriate tests and exams and everything for preventative care. And I think preventative care is the key word.
Yeah, to me, that's one of the key things is if you're going, so I get a physical every year, as you well know, and if I go once a year to get my prostate checked or to be, screened for colon cancer.
Yeah, it's once a year. I don't know why you're coming in 3 times a year, but that's okay.
Because you give away free lollipops, but
Okay.
that's beside the point. So when I come in, I'm getting screened for prostate cancer. I'm getting screened for colon cancer. I'm getting whatever. I'm getting an EKG. I'm getting a lot of things done. If I do that once a year, the odds of you, in this case, catching something early that can be fixed are reasonable. If I go every 5 years or every 7 years, or worse, when I feel terrible, the odds of catching something early and being able to do something about it clearly diminish greatly. So I think that's a big part of it is education. And like you said, do they not want to pay the copay? Are they concerned, well, you will find something and now that's going to cost a bunch of money. So just from a preventative standpoint, I think that's got to be huge.
And it just occurred to me, if I switch chairs and sit where you are from the economic side of this, and you're always helping people grow their wealth, preserve their wealth, and so forth, people don't realize that preventative care is actually a lot cheaper than reactive care, which is where you have a heart attack or cancer or whatever. If you can either mitigate that disease or prevent it altogether, it's way cheaper. Mm-hmm. And in fact, the selling point I have for my membership practice is if I may be able to save you the money you're spending on me by keeping you out of the hospital, by preventing major surgery or major illness. And it's hard to run scientific numbers on just one person's practice, but I do log every admission that I have and every death. And as I look at my admissions, a lot of them are joint replacements, for example. Very few are for heart attack or stroke because most of the time I can catch the disease process early. And then when I look at my patients who have died, they're generally in their 90s.
Yeah.
Very, very few people die prematurely of unexpected illness.
The other part that I find fascinating, and we talked about this actually on the last time you were here, is also the discrepancy in diet and exercise, and that I think a lot of that just again boils down to education. If I was tempted to go by Walmart or somewhere and buy a big bag of Cheetos, which costs like $1.89, and it's this big, versus a banana or something, or a bunch of bananas, which probably cost the same, right? So you got this little thing of bananas, 4 or 5 bananas, which costs a couple, $3 or $4. I don't even know what bananas cost, but it's somewhere in that neighborhood. And a bag of Cheetos, which is literally 4 times as much food. And what happens is people who don't have means lean towards that big bag. Obviously, it's a metaphor for a lot of things, but that big bag of Cheetos. And then the other part is the understanding of the importance of exercise in somebody's life. I know for me, we talked about it last time, for me it's a mental thing. Not only do I want to feel good and look good, but mentally, if I don't exercise, if I don't get those endorphins, I work in a pretty high stress profession, I start to lose it a little bit. So I think mental health outcomes are the other underappreciated thing, is that the low level of anxiety that somebody gets from not being able to pay their bills, from worrying from day to day, how's the electric bill going to, how am I going to put my kid through college? I think these are things that are underappreciated in our society today. Now, the other part of it is alcohol consumption. And you talk a little bit about what you've seen there in terms of actually wealthy people and people who don't have means.
Well, you went over an entire slate of things that I could individually talk about at length. As it turns out, processed and fast food is quite a bit cheaper than healthier foods. And in fact, even though I don't usually look at prices too much when I'm going to buy bananas, for example, because I'm going to buy them
right
anyway.
Either way.
But when you do start noticing the price of strawberries or blueberries or asparagus or whatever, you realize, wow, it really does add up. And it might be cheaper to go to McDonald's and get a whole load of food for much less money. And so that is the unfortunate part. And as far as exercise, you can get a pair of sneakers and some hand weights, and you don't need to join a gym. But most people have the mentality they have to join the YMCA or a gym or something, and they just simply can't afford it. But it just doesn't become part of their lexicon of their daily routine to exercise, not only to stay healthy, but also for stress reduction and maintain a decent human body, as it were. But the thing, what was the last thing you were asking me about?
Well, just talking about what you see in terms of alcohol consumption. One of the things we talk about is, you and I were just talking off the air, or I thought off the air. Apparently Vinny was filming the whole thing, so he'll use it to blackmail us later. But one of the things we were talking about is alcohol is the one thing maybe that income isn't creating a big disparity, meaning people of means sometimes overindulge or self-medicate. So maybe you want to talk a little bit about the long-term effects of that for maybe both of those groups of people.
And for that topic, as far as comparison throughout socioeconomic groups, I would have to rely on data. You tend to see, you can pick out the people who are alcoholics around town because they're riding a bike to work or to the bar, and they're clearly not cyclists, and they've lost their driver's license. There's a lot of blue-collar workers who, after work, instead of going to the gym, they go to the bar and have a couple of pops. But it is not a rare thing, even amongst the higher socioeconomic people. They can just afford better liquor, basically.
Right.
And they'll head to the country club or the tennis club or whatever to meet with their friends on a regular basis, particularly after retirement. And alcoholism and alcohol issues are pervasive. And they cause all kinds of things, from emotional issues to heart issues to blood pressure issues, and obviously accidents, falling down at home, falling off a chair, banging their head, and of course car accidents too.
Yeah.
So I don't really know how it divvies up amongst the different strata of society.
I mean, just anecdotally, from my experience at both ends of the spectrum, I don't think it's limited to one or the other. I think alcohol is the one common thread I see. Like you said, I think the $40 bottle of Pinot versus the 6-pack of Busch Light. I've had both, by the way. Quite wonderful. I don't know that is related to one group or the other. I think it's uniform across all wealth spectrums. But with that said, one of the things I was looking at here is I was looking at diabetes, for example. The prevalence of diabetes for folks who make less than the poverty wage, statistically, at least according to this study, is about 18.5%. For people who make over $120,000 a year, it's less than 7%.
So those numbers sound low to me.
Yeah, really.
Yeah. Overall, but obviously the delta between the two groups is what you're focusing on.
Right.
Yeah.
Again, money and money isn't, as they say, isn't everything, but people with money tend to be educated. They tend to read a little bit more. They maybe came from a wealthier family where exercise was emphasized, or I know when we reach out to socioeconomically challenged youth, which my wife and I do in the community quite a bit, they are so far behind on understanding diet understanding how carbohydrates work or fats. Their idea of nutrition is completely lost because nobody's ever sat them down and explained how it works or the benefits of exercise. So I just wanted to get that out and have that conversation. And again, it's not limited. Poor health isn't limited to folks who don't have means, but I still think it's important for, in my case and really in your case, our clients to understand that, and maybe they are at the wealthier end of the spectrum, but getting that education out to everyone is certainly helpful for society on the whole.
Yeah, it's a challenge, and one of the things that I see, because the people that come to me are self-selected, they're paying a fee to come see me, and so they are already invested in their health. So I would say that the rates of obesity are much lower in my practice, and very few of my patients smoke. Alcoholism I see as two different issues. One is the person who's genetically predisposed to alcoholism and is an alcoholic. That cuts across all socioeconomic levels. I doubt there's any difference there. The rest I would say would be social alcohol abuse, where somebody may not strictly be an alcoholic by definition, but has gotten into a cycle of meeting with friends on a regular basis and drinking to the point where either the calories are a problem and causing some weight gain, or thinking can be impaired, either short-term or even long-term at times. But as far as trying to educate people on diet, let's say, it is a lot of work. And even amongst people that, let's break it down not so much to socioeconomic strata, but to different intelligence levels. They did tell me in medical school that when you're talking to a patient in an exam room, they will remember 10% of what you tell them. And I have found that to be true across the spectrum. I am constantly writing notes, reminders. If it's really complicated, I'll give them a copy of the office note for the day, and in order to have them follow what I want them to do. But as far as instructing people on dietary knowledge, it's hard to do it in an office visit. Again, if you've got people absorbing 10% of what you say. So you have to kind of stick to simple themes. You have to kind of guide them to internet resources, and in some cases to community resources. For example, the Crosby Wellness Center, they've built a brand new building that's gorgeous, and they've got a kitchen in there where they do instructional cooking classes, and they can be geared towards diabetes or other disease processes. So I tend to refer quite a bit over there, because if you really want people to change their behavior, just talking to them in the office, you can guide them in the right direction, but you really it has to be a much bigger emphasis than that.
I want to pivot a little bit here and talk about your practice for a second, because I don't know that we've done a great job of that before. So I think for a lot of the people who are going to watch this, your concept is kind of interesting and probably new to most of them. You and I have discussed a few times. I've seen people try to do what you do, which is concierge medicine, and do it okay and sometimes not so okay. But you've been very successful at doing this, and granted it's Winter Park, so that's helpful. The zip code's helpful, as I just identified. But can you kind of walk me through what caused you to want to do this? I know you had some experiences in the general medicine world that led you down this path. There were some personal reasons you wanted to do it. There were some convictions you had about life that made you want to do it. I know having a garage with your sports car in it was helpful. But beyond that, can you walk us through kind of how you created the situation you now find yourself in?
Sure. So I finished my residency in internal medicine in 1991 and got a position out here in Orlando. The first job I had, I was working for a Humana organization. It's HMO, very restrictive. That job, after my 1-year contract, I moved on. It was that's a whole nother podcast. But from there, I joined a run-of-the-mill standard internal medicine practice in Winter Park. They were one of the best internal medicine practices. It was insurance-based, and I worked there until 2008 when I started my current practice. In a standard fee-for-service practice, you only got paid if you saw a patient, and that payment came from insurance, whether it was Medicare, Blue Cross, Cigna, whatever it was. What happened over the years is the insurance companies and Medicare would pay you less and less per visit, and you had no control over that. And so subsequently, over the years, you had to see more and more patients to make the same amount of money. At a certain point, I was seeing about 20 patients a day, and I was overwhelmed. At that time, my accountant said to me, do you realize your income has dropped the last 3 years in a row? And I was getting busier, making less money. I was finding out that drug reps were making more money than I was as a physician, and I thought, after all the schooling and knowledge that I have, there's something wrong with this picture. Mm-hmm. But what I found being that busy is I couldn't really be a doctor anymore. There's a comical term, I don't know who's coined it, maybe I made it up, and it's called being a referralist. You don't actually diagnose anything. Somebody comes in with an earache, you refer them to ENT. They come in with a cough, you refer them to the pulmonologist. They have some chest pain, you refer them to the cardiologist, and you're doing that all day long. You're not really being a doctor anymore. I came out of training, I had very strong training both in medical school and residency, and I was trained to do spinal taps, bone marrow biopsies. I could drain lungs, abdomens. I could drain fluid out of joints. I could put lines into the heart. I mean, we were trained to do it all. And of course, that's mainly because internal medicine is a launching point into the various subspecialties. But nonetheless, I felt that all these skills that I had were atrophying. And I was doing less and less of what I was trained to do. And I finally said one day, this is not fun. I'm no longer being a physician. I'm being hampered both by what I can do and also by a decent livelihood. And a patient of mine said to me one day, he said, sometimes I just have a question. I can't get you on the phone. Your staff won't let me talk to you. Or I have a sore throat. I can't see you for a week. By the time I have an appointment, it's either better or it's much, much worse. Why don't you try starting your own concierge practice? It's also called direct pay. It's called membership practice. There's a whole number of names for this. But effectively, I had no idea what he was talking about. And so I started researching it. And what you do is you charge an annual membership fee. Now, some doctors will also bill insurance or Medicare. But I found with Medicare, you could get in trouble for what they consider double dipping. You're taking Medicare payment and you're charging them an additional fee. There's laws against that, and so I opted out of Medicare. And then with insurance companies, they fight you tooth and nail just to pay you, that you end up paying half your fee to administrative personnel just to collect the $50 or whatever it is. So I actually don't bill insurance for anything. Now patients come to me and the insurance is used for when I draw labs or send them for x-rays or for other doctors. You fast forward from 2008 to now, and I have interviewed several doctors in an attempt to grow my practice. Several of these doctors are working for some of the large hospital systems, and they are now seeing 40 patients a day. And when you have a patient that comes in with diabetes and high blood pressure and cholesterol, and they have anxiety and their left toe aches, and can you look at my ear, and I got the spot on my back, I don't know how you can see 40 patients a day and practice good medicine. So the system's becoming more chaotic, more complicated, and at the same time, because I've made the leap, and I normally see, it's not apples to apples anymore, because I may see 10 patients in the office, but I may handle 20 patients via telephone calls, emails, texts, whatever. Now I can handle the problems in the most efficient way without clogging up the office with a huge number of patients.
Most people don't want to come in if they don't have to.
Exactly. Some people have a pink eye and they send me a picture of their eye. Do I need to come in, or is this something you can handle? Boom, I see the picture. I'm like, yep, you got pink eye. And here we go. I'm sending the eye drops to your pharmacy, problem solved. And so that's how I jumped in 2008 to this. It was literally jumping off a cliff. I had no idea whether I'd be successful. I was almost the first guy in Winter Park. And there really weren't that many people doing it when I did it. I went to the bank, got a loan, rented an office, hired some people, got some software and hardware equipment. I had some patients from my old practice who followed me over, and slowly grew the practice to where it is today.
A doctor and an entrepreneur.
Yeah, I kind of got an MBA through the School of Hard Knocks by making some good decisions and some bad decisions along the way, and also surrounding myself with people who know more than I do about business and finance and so forth.
I just think that it's, correct me if I'm wrong, because every time you and I talk about this, I leave a little bit angry, because you think about the healthcare system and how jumbled up it is. What a mess, 40 patients a day. I mean, I know sometimes when I go to a specialist for whatever I have to go for, they're always nice people, but they got one foot in the door and one foot out the door, and they seem to be carrying some kind of monitoring device with them, almost like an ankle bracelet that's going to go off
right.
if Big Brother finds out they've spent more than 3 minutes with me talking about whatever it is. And when people go to the doctor, they're nervous.
Yeah,
that's just natural. Like, okay, what's this guy going to tell me? Give it to me straight, doc. Well, you have a hangnail, so shut up. But that is a thing. We want to be talked to. And you're right. We may only hear 10%. But we want to hear the 10%. We want that time. And I think between insurance companies and large healthcare outfits, I won't name any names.
Right. I was careful to remain anonymous.
Yeah. I won't name any names that owns all the real estate in downtown Orlando. But they seem to be squeezing doctors and patients, and to some degree, I think, pitting them against each other.
Yeah.
Because I think a lot of times I talk to people, I'm like, well, that doctor this, and he makes all this money. I'm like, I don't think they make as much money, number one, as you think they do. And the only reason they're hurrying is because they don't want to lose their jobs, right?
Right.
So am I fair in saying that that's the landscape, kind of?
In the past, doctors used to own their own practices. They'd have group practices and so forth. I would say it's getting close to 90% where physicians are now hospital employees of one hospital system or another.
Right.
And now they basically just show up for work and go home, do what they're told to do, and that's that. In a way, doctors aren't generally good businessmen anyway, so trying to run an office for a physician is not easy. I have learned that. But in another way, you give up autonomy, and now you're told to see 40 patients, and somehow you get it done. And then nobody's happy. The dissatisfaction amongst physicians is enormous. And as you say, on the flip side, the patients are not very satisfied either.
Right.
Now, the medicine is also fascinating. I mean, there are advances made all the time. The COVID vaccine, I was listening to the news right now. It is a miracle how good the vaccine is. It is way better than any vaccine we've ever made. And so far, we're finding it to be quite safe, despite everybody's worry.
Right.
But it's miraculous. The fact that the mask mandate was lifted yesterday was due to the numbers coming out better than expected. And I won't go into the details, but it takes money to create these breakthroughs. However, there's also a lot of profit that's being made in the medical world, but it's concentrated in certain areas, usually at the top of the mountain. Mm-hmm. And doctors in general do better than the general population.
Sure,
so I don't,
as they should.
Yeah, but I don't want to, cry that we're poor and this and that.
Right.
But it does take a lot of years and a lot of money to get through medical school,
right.
And you don't actually start making money until you're probably in your mid to late 30s.
Yep.
Once you pay off all the student debt. Nonetheless, what I'm finding is in this system, the doctors are the infantrymen of the Army. And the top of the heap are the hospitals and the insurance companies, and they make scads of money. And so sometimes you wonder, are they really having physicians see so many patients because that's just the way it is, or to maximize profits? It's probably somewhere in between. But I think at some point you reach a breaking point where the doctors just aren't doing an effective job anymore. And I don't know if we're there yet, but if we're not, we will be there. And I saw that coming so many years ago, and I positioned myself. I didn't know if I was going to be successful, but I knew, according to my machinations and my mathematics, the probability was high, and I have been spot on.
Yeah.
I am very busy. I had to shut my patient list down for a while until I got a nurse practitioner that just joined me. I've opened up membership again. I will probably have to shut it down again until I can get another doctor, because people are fed up.
Yeah.
They're not getting listened to. Their problems aren't getting addressed, and they're finally saying, "All right, I'm willing to pay this money to get the health care that I want."
And I honestly don't think it's is as expensive as people would guess. I'm not saying it's cheap or free, but I think if you actually did the math, I'd be very interested to see a study of how your practice runs and what it actually out-of-pocket costs for someone who is in your practice versus somebody who's, first of all, going through all the channels to get to see a doctor, sitting in a waiting room for 2 hours to be seen for 30 seconds, and sitting in, I feel like, when some of these places I used to go to, you'd sit in the waiting room for 2 hours. They had no concern that you were 2 hours past your appointment time. I'm watching the goldfish go round and round for the 80th time. Some bad TV's on. Then I go into the waiting room. I put on the really sexy gown, and then I sit there for like 40 minutes.
You always put it on backwards, I've noticed.
Yeah, I do put it on backwards, which is always awkward. Sorry about that. I'm reading the bad magazine, or I'm playing with stuff I probably shouldn't be touching, that kind of thing. So yeah, I think that the experience would be surprisingly pleasant and cost efficient, at least compared to what people think.
It's like doing a study that doesn't have enough patients to be statistically significant. It would be very hard to look at my patients and make any dramatic conclusions that would be statistically significant. But there is a franchise called MDVIP. They started out of Boca Raton, and they've expanded. As far as I know, they're all over the country now. And doctors will join the franchise, and they help them set up concierge practices and so forth. And I believe they are accumulating data and putting out some reports. Obviously, it would be to their advantage to show that they are providing a superior product.
Right.
So I would ride on the coattails of that. As you alluded to earlier, however, doctors all across the field, and including in what I do, are not homogenous. You have some doctors that do an excellent job and some that don't do an excellent job. What I find in doctors who do what I do is they're usually at the tail end of their career. They're tired, they're exhausted, they don't want to quit yet, but they want to make a decent living. And they go ahead and sell their practice. I'm sorry, they don't sell the practice. They transfer their practice into a MDVIP franchise, for example. Very few doctors will do it on their own. I decided to do it on my own, and there are reasons for that. It's been very beneficial. And then they just kind of work a couple more years and then retire. And the patients certainly have better access to them, but I've had patients transfer even from those practices because they tell me that the doctor doesn't return their phone call, or they call for an appointment, he's on vacation yet again. And when I realized when I did this, if you promise to be available, you've got to be available. And this is not, you can't just make a bunch of money and then be on vacation all the time. So you have to be available. You have to be in the office. And if you're not going to be in the office, you have to have other people in the office to take care of patients.
Which you're working on right now, actually.
Well, yeah, I have. For the first time since 2008, I went on vacation with one of my daughters and did not have to call the office 10 times a day or log on to the software and review notes and labs and documents and order tests and so forth. So basically every time I went on vacation, I was basically going out and doing a hike and then coming back and at lunch and then working and then going out and going whitewater rafting and then coming back and working some more. And the staff would call me wherever I was. And that was okay. I got used to that. But this was the first time my nurse practitioner told me to stop calling the office. That she's got it under control.
Good.
So it's nice.
Well, I think it's a concept that's not understood very well. It's obviously you don't have the lobbying power a giant hospital group does, but I do think it's something that needs to be talked about more, and I think the economics of it needs to be understood a little bit more. So I'm actually one of the things I'm going to try to do after this conversation tomorrow or the next day is look up and see what statistics are available on that, because I do think it's something that people who are watching this would probably be interested in. So
I could tell you one thing, and they didn't do this enough. The hospital would put out metrics, and I always enjoyed getting my metrics, and it had to do with average length of stay. In other words, they would take 3 diagnoses, and I remember one was pneumonia, and they'd give you a bubble chart, and they would show you how you would compare to your peers. In other words, it wasn't just that you got your patients out of the hospital quicker than other people, but the outcomes were better. The pharmacy utilization was lower. Incidental equipment charges were lower. And rehospitalizations were lower. And so they did put out metrics saying you're actually doing a better than average job with these 3 diagnoses. I loved getting those metrics, and I wish they haven't done that in years, and I wish they had kept doing that.
Yeah.
Because one, the feedback helps. If you are keeping your patients in longer, you got to figure out, do I have sicker patients or am I doing something wrong?
Mm-hmm.
But again, not having to hustle and being able to spend time, not only can you treat patients well, but a lot of times they don't even go to the hospital.
Right. And again, that where we started with all this is the socioeconomic relationship to healthcare and outcomes, and I think that's the advantage your patients have, is that the preventative side of that, the conversation before something gets out of hand or even occurs to begin with, I think is critical. Well, anyway, this was awesome.
Great.
And hopefully enlightening. I know Vinny's enlightened.
He's fascinating.
He's just, are you awake, Vinny? Okay, he's awake. Anyway, that's ScottCast, the podcast.
Perfect timing.
Yeah. He needs another beer. Number 28 in the books.
Podcast or beer?
No, not 28 beers. Not since college. Number 28 in the books, ScottCast, the podcast. Thanks for tuning in.